All right, now let's talk about ARDS diagnosis. Now remember in ARDS is that pink soft lung tissue has turned hard and is fibrotic. So remember, gas exchange is not going to be as good. Ventilation is going to be harder because you're going to have stiffer lungs. So diagnosis, clinical diagnosis of exclusion. Now biopsy is the only way to really diagnose, but you're not going to be able to do a lung biopsy on a patient this sick. And it's dangerous. A patient would probably die from the biopsy procedure. To get in these patients that are extreme respiratory difficulty. So Berlin criteria, it gives a sensitivity of 89% with specificity of 63%. So what are the criteria? Symptoms have to begin within 1 week. Bilateral opacities on chest X-ray or CT. We need to rule out heart failure. PO2, FiO2 ratio. Remember the PO2 is just, we're going to get that from the arterial blood gas. Divided by the FiO2 that you're giving to the patient as far as oxygen. Need to be on a PEEP greater than 5, CPAP greater than 5, mild ARDS. So the importance on these is that the milds, moderate, and severe, these give you a prognosis of how the patient's going to do. Mild ARDS is going to have greater than 200 millimeters of mercury, but less than 300. The severe is less than 100, so your PO2, FiO2 ratio. The purpose of this is to show your increased morbidity and mortality. So now we're going to talk about vents. All right, we have a full lecture on venting. We're going to give a short little snippets right now to help you with what you need to pass on boards. But we're going to talk about vent in the world. Now, we can see right here is that there's all different types of ventilators, but they all do the basic same thing. They all have this, and the reason why they're all different is because somebody wants to make money. They have a great idea how to make the interface more easy to use, more with these GUI interfaces so that it looks prettier, but these actually can be helpful in taking care of the patients. But the basic module is the same as you're getting air in, getting air out, you're doing gas exchange. The machines get fancier, but the vent is just a bill. In fact, here was the first vent, it was a blacksmith bill. And then back in the day, guess what they had? Guess who the ventilator was? The people who did the ventilators was the students. The medical students had to do it. The residents, they would bag because guess what? Back in the polio days, they didn't have enough ventilators. And that's what they did, is you ventilated with hand motion. So yes, the ventilator, yes, certain brands probably are better than others, and you may enjoy using one ventilator over the other, and I certainly do. There's some ventilators I don't enjoy using, but the basic function is the same. Now we're going to talk about setting up the ventilator in ARDS, maybe all patients, because kind of the way things change is that they're very similar. Now the mode, most of the modes, and when you're testing is going to be for CMV. You're going to see when you go into a hospital, unless you're going to a very special ward, is that say 90% are going to be continuous mandatory ventilation. You want to keep the tidal volume goal. Initial setup is going to be 6 to 8 milliliters per kilogram of ideal body weight. And this is very easy. There's multiple apps that will show you this. You can get the ideal body weight from looking at these apps, getting it based off the height. Height and sex, that's all you need is a height and sex. You get the ideal body weight. From the ideal body weight, you times either 6 to 8, and you're going to set your initial tidal volume in those ranges. As the patient gets better, your goal is to drop the tidal volume. The goal would be 4 to 6. Remember, this is the whole purpose of the ECMO, is that the ECMO is going to help with perfusion and gas exchange so that you can drop your tidal volumes. In ECMO, if everything's going well, you can drop the tidal volumes as low as 2 milliliters per kilogram, even lower. So that way, there's less stress and distension on the lungs, and we'll talk about that. Your PEEP, there is a great website that gives you ideas on PEEP. You can see these here. There's low and higher PEEP. The lower PEEP is pretty much what we're going to see commonly. The higher PEEP, this is not as many people use this, but it's still available. This is ideas, and they've come up with ideas for you can PEEP. Now, the peak pressures, we'll talk more about this, and you can, as I said, if you need more in depth, we have a full ventilator lecture for you, is we want to keep our peak pressures less than 30 centimeters of water. And then our rate can be anywhere from as low as 6 to as high as usually about 36 is where it's going to cap out, 35, 36. Our goal pH is, in ARDS is we want to have it greater than 7.2, excuse me. We're never going to get, well, how about this? The goal is to get to 7.35 to 45, 7.45. But in the ARDS, we're going to be happy to get these patients greater than 7.2. We have a PaO2, we want it between 55 and 80, and the SpO2 between 88 and 95. We're going to see probably this 95 is going to go away. I would say in the future, you're going to see is 88 to 90, is we're seeing where lower oxygen is probably going to be better for these patients. All right, now let's talk about why it's important where we're setting the tidal volumes. So back in the day, we used to use low PEEP. This is PEEP right here. Now what is PEEP? This is the end expiratory pressure. So this is the pressure at the end of ventilation. And we'll give an example, we'll help out on this. So you used to use low PEEP and high tidal volumes, okay? Now see the difference between here? And I want you to think about this as being a balloon. This is our individual alveoli. And see when you have this, and we'll give an example, and I'll actually show you this, is see this distension? When you have a low PEEP and a high tidal volume, you're gonna think the alveoli shrinks down really low and then distends out. It shrinks very low and distends out. Versus if you have a high PEEP and lower tidal volume, this is what's suggested now, is that you have less distension. So the balloon collapses like this and goes back up like this, less distension. The theory is you have less inflammation when you go like this, where you have a larger PEEP, smaller tidal volume, you have less distension. That less distension leads to less inflammation. Less inflammation leads to less cytokine release, less chance for getting ARDS. So here again, when you go from this to this, to this, to this, you're gonna have more chance for inflammation. Here, let's do an example. We got a nice little video show you. This is just a balloon. This is representing an alveoli, okay? Now right here is this, we extend it. Look how big that is. And then we come down to nothing, right? Now we're doing is this is where we have high PEEP, low tidal volume. You have less distension of this balloon, less distension of the alveoli. This is an example, show you. We'll do it one more time here and look at it right here. Big distension out to shrinking down. Just think about all the information from this is having from the distension and from going back versus here we have is the PEEP and we distending out less. So that's why we want to consider having high PEEP, low tidal volume. The tidal volume ranges between 6 to 8. So we basically showed you how to set up a ventilator. You set the tidal volume between 6 to 8 of ideal body weight. Your respiratory rate is going to be determined anywhere from 6 to, say, 36 is where you're going to cap out most. Now remember, if you want to if you're acidotic, right? You're acidotic, that means you have a higher CO2, so you want to do what? You want to increase your tidal volume and your respiratory rate to burn off CO2. If you're hypoxic, you want to increase your FiO2 and your PEEP. This will give you more greater oxygenation. So tidal volume, which we talked about, we'll go back to that slide one more time. So how to set this up? Tidal volume between 6 to 8 of ideal body weight. PEEP, you can use these ARDS, not probably going to use the lower ones under. You're going to have a minimum of 5 in most cases, and then the max, that can be controversial depending on where you practice. Breath rate is going to be as low as 6, high as 36, and you're going to adjust it based off the patient's lungs themselves and how the patient is doing. If they have an underlying disease, where if you make the respiratory rate too much, you can have breath stacking, but you still need to burn off some of the CO2. Our goal is once we set it, we want to do a follow-up gas, and we want to have our pH greater than 7.2 if possible, and we want to have our PO2s be serving these range as discussed. We talked about how that distension. Now, when we have a patient on the ventilator, we need to think about what we need to do to keep them on the ventilations. Now, first we have to think about, is this patient unstable? So if this patient is unstable, we need to sedate them and give them analgesics, okay? And we need to consider paralyzing. Why do we want to paralyze this? We want them to stop pushing against the ventilator. If they push against the ventilator, we're not going to be able to ventilate them properly. Now, once we put analgesics, these are going to be for pain, sedation, and then we paralyze them, we need to follow up to make sure we're not doing what? We're not giving them too much analgesic, too much sedation, too much paralytics. We have to remember is any patient we have, I don't care for inpatient or outpatient, the more benzos, the more opioids we give them, the greater risk for delirium, dementia. Delirium can convert to dementia. Once somebody has delirium in the hospital, It can be seen on MRI, okay? Regardless of the fact if they've had a neurological event, they can have a problem and they can see it on the MRI. It's a definable thing. Mortality goes up. So increase amount. So we want to use the minimum we want. So there's different scoring, and you may use different scoring in your systems, but you can use a CPOT scoring. That's to check the pain in the ICU. To remember with the critical care pain observation tool, and you trying to limit the amount of opioids you put in the system. If you can get away of just doing pushes when the patient needs it, and you're like, oh my gosh, they're on a ventilator, they need to be knocked out. They don't need to be knocked out. You just need to get them sedated. Now, if they're unstable, you're gonna have to give them high levels of sedation and analgesics and paralyze them in some cases to make sure that they're not fighting the ventilator. Another thing you can do for sedation is you use RASS. This is one of the scores. There's several of them out there. Is the Richmond Agitation Sedation Score. Basically, what you're doing is seeing how agitated they are, and you adjust it. Now, your medications that you use for this, first of all, for pain, usually on the ventilator, we want to use goal of using pushes such as fentanyl, morphine, or hydromorphone. We want to keep them, remember, we want to avoid morphine in patients who have chronic kidney disease because the morphine metabolites can build up. So what we want to do is minimize our sedation if we can get away with pushes instead of drips. And then we do our RAS score, and we have to determine, so medications we can use are dexmedetomidate, this is for agitation, propofol, Versed, and Ativan drip. We would prefer to do pushes. Propofol is preferred, and dexmedetomidate is preferred over the Versed and Ativan because we want to reduce the amount of benzos and opioids. And then we use a follow-up, we use a CAM-ICU, is a confusion assessment method for the ICU. We're trying to avoid delirium. And we only are paralyzing when we can't ventilate. Paralyzed when we ventilate, we want to try to paralyze as minimal as possible. We want to only do it when we cannot ventilate the patient, and we're trying to get the paralytics off as soon as possible. What do we have problems with paralytics? You get you get myopathy, ICU-related muscular breakdown where these patients are weak, they're hard to get off the vent. Then these are things that we want to avoid. We want to avoid having them on paralytics for long periods of time. How do you chest with somebody for paralytics? You can't ask them, hey, can you raise your hand if you're paralyzed enough? No, they're not going to raise their hand. They're paralyzed. So you do what's called a train of four. And not everybody does these, but you can look and see. There's a train of four. It's just a little electrostimulator, and it's a nerve stimulator to assess the nerve function in patients receiving neuromuscular blocks. You don't want it to be so paralyzed as they have too much that when you cut off the paralytics, it takes time for them to wake up, but you don't want them under paralyzed. You either place these, they have probes on there, and I'll show you the next slide over what they look like, and you either place them on the ulnar or facial nerves, and it delivers 4 electrical impulses, train of 4, right? And you want to get where watch the patient, so you press, you're going to press and give it a pulse, you press the button on there, and you're going to watch the patient. You're going to see how many twitches they do. 4 out of 4, you're 4 out of 4 right now, meaning that you're not paralyzed. We hit it, it's going to give 4 impulses, you're going to have 4 twitches. 0 out of 4 means that you're basically having too much, your paralytic is too much. There's too much. In most systems, 2 out of 4 is the goal that you get 2 twitches with the 1 push. So you do 1 push, it gets 4 impulses. You don't push it 4 times, you hit it once and it gets 4 impulses. All right, here's an example. This is the monkey. This is the stupid monkey was me, okay? I can call myself a stupid monkey, okay? Not a big deal. All right, right here, these are the little electrodes. We put those on there, and I'm gonna shock myself. There we go. And shock, and you see, I twitched. I didn't twitch 4 times, so I probably was paralyzed when I was doing this. Does it hurt? Yeah, it kind of does. So, and when you hit the button, I should be twitching 4 times. If you look at it closely, you can see that. All right, so those are a brief discussion on the ventilator. Remember, we have a full ventilator lecture for you to go and get more detailed information on ventilator. We're going through this, so we're getting this for boards. Remember, what you need to know for ventilators is really easy. If the pH is low, you want to get the pH up by getting rid of CO2, okay? Getting rid of CO2 by increasing the respiratory rate or tidal volume, boom, done. If they're not oxygenating, you want to increase what? The PEEP and the FiO2. Done. That's it. That's boards. You got it. Done. You got it. If you need more information, go to the deeper dive lectures. All right, so we have a patient, 42-year-old male with unknown past medical history, complains of abdominal pain. So what? What? No big deal. Abdominal pain. All of us have abdominal pain. Well, this guy's abdominal pain was significant. Guess what? It radiated to the back. We took a lipase. The lipase was elevated, and then we did some imaging, and the imaging showed an inflamed pancreas. What do we have? We just talked about pancreatitis, similar to our poor gentleman who had a compartment syndrome. And what's the big deal? He had abdominal pain. Remember, you can have tooth pain and have an MI, right? Tooth pain can be had cases of tooth pain leading to MI. So what's this guy got? Well, the nurse, you order some labs, and the nurse draws the blood out, and this is what you see. Oh, look at that. Look at that. What is that? Is that normal? So what this gentleman has is a hypertriglyceride-induced pancreatitis. Now, we talked about the levels need to be greater than 400. Now, where did they get the 500 from? Well, back in studies back in 1975, they had alcohol-induced pancreatitis, and they gave them high doses of lipids. They drew their blood out. Their lipids levels were at 600, and these 11 out of the 12 of them developed triglyceride-induced pancreatitis. So they said, hey, that's the number it needs to be. But here again is this, even if your baseline is 500, if you're consuming high amounts of triglycerides, you're eating a Western American diet, and you're eating ice cream all day long, and it can get your triglycerides high enough where you can induce this. So we have increased free fatty acids, which convert to trypsinogen into trypsin, leading to autodigestion and pancreatic inflammation. Basically, I want you to think of these triglycerides going in the pancreas, gumming things up, and you have autodigestion of the pancreas. Does it hurt? I've heard it does. I heard it's very horrible pain, okay? I have not had this, and I hope not to have this. So how do we treat this? We need to give fluids, but also we need to do is there's kind of two schools of thought, and we'll kind of go through these. But first is that you can give high amounts of insulin, and the insulin inhibits the synthesis of lipase, which of lipoprotein lipase, increases the synthesis, which hydrolyzes the triglycerides, and inhibits the lipolysis from fat, and reducing the production of free fatty acids. So one way is insulin can be, there's another process called apheresis, and it's really cool, is where you basically spin out the fat. All right, so here we did a clinical scenario. Now we're going to do the actual board review question. Remember, this is horrible board review question. I want you to think the word horrible, get over it, and just work on the question. Get the emotions out of it so that way you can focus and use the rest of your brain with no emotions and do awesome on these. So which of the following is the most appropriate next step in management of hypertriglyceride-induced pancreatitis? Oh, I think I probably gave you the answers on this. Oh, what a poor person I am. Bad teacher, right? Initiate high-dose statin therapy. Well, begin intravenous insulin infusion. Oral omega-3 fatty acids. What would that be? Fish oil. Fish oil is very similar. Begin plasmapheresis and begin oral fenofibrate. What is the answer? See this right here is the next step. Most appropriate next step. Are these all possibly right? Yeah, could be. So this is a 38-year-old male with poorly controlled diabetes mellitus type 2, presented to the emergency department with severe epigastric pain radiating to his back. Nausea and vomiting. Laboratory studies reveal a serum triglyceride levels of greater than 1,000, 220, 2,200, elevated lipase, and this lafazosimerum. I can't even say it, I'm so tired. So basically, we looked at what we had over here in that tube. Look at that tube right here. Boom. So we're back. After stabilization with IV fluids and analgesia, what is the next most important step in treatment? And I gave you the answer. Begin IV insulin infusion. Now, all these used, yes, but it says what is the most important, most appropriate next step? There it is, right there. Now, are you going to give statin? Yes, you are. And in this case, you would give an oral fenofibrate with the statin at the same time. I know that can cause myopathy, but in this case, it's important. You can begin oral omega-3 fatty acids, which is your fish oils. Now, plasmapheresis or apheresis can be done, and we'll talk about that. usually in current literature is IV insulin infusion is being done first